This webinar series was developed by the Colorado Older Adult Falls Prevention Coalition, specifically the community-based Older Adult Falls Prevention Team. Members of the team represent hospitals, public health, and other organizations. The team's mission is to reduce the risk of falls through education, raising awareness, advocacy, and improving access to resources. The role of the team is to provide leadership and guidance for local falls prevention efforts. You will be receiving an email asking for your evaluation and comments about this webinar. We ask that you please respond to that email and actually provide any comments at previous webinars as well. Thank you.
Okay, this is Sally Thorson with the Colorado Department of Public Health and Environment, and I'm facilitating this particular session. We're going to have 3 speakers, Vicki Kassebaum from St. Anthony's Hospital, and myself from the Colorado Department of Public Health and Environment, and then Wayne Marshall from the Colorado Center for the Blind. And I'll give a little information about each speaker right before they talk. So our first speaker, Vicki Kassebaum, is the Injury Prevention Coordinator at St. Anthony's Hospital in the Trauma Program, and she's developed and implemented many educational and behavioral change programs for older adults regarding fall prevention as well as other topics. And Vicki's going to talk to us about age-related eye diseases, just to give us some background on that part of the problem.
Good afternoon. I am happy to be here with you this afternoon, and I'm going to go through some basic information about age-related eye diseases. The one thing I want to point out is that I am using a PowerPoint that I was given access to. Actually, Sally Thorson directed me to this, and it's a great resource for educating the community on age-related eye disease and conditions, and they have the PowerPoints, the presentation outlines, and many tools on this website, which I will have listed at the end of the presentation. So the basic purpose of this presentation is to give information on age-related eye diseases and conditions that can cause permanent vision or blindness, and those we know are common factors which will lead to falls. The thing about eye disease is that they often have no early warning signs, so a good comprehensive eye exam is recommended on an annual basis, and something of importance that we should be educating our older adults about. As far as vision changes go, you can go without noticing any changes until they become a big problem, and that many changes that are common can often be corrected. So the biggest key that we can give to our older adult population is that if they do nothing else about their eyes, that having that eye exam annually by an ophthalmologist with the dilated eye exam is really paramount, because the earlier that they can stop these processes, the better it is. So as we age, they say that vision starts to happen with changes as early as our 40s, and we all know that by our arms aren't long enough to read anymore, and that they're very normal and common, and that some of the key things that happen is that we'll lose focus, which makes it harder for us to focus vision up close, thus the reading problem. We have a declining contrast and color sensitivity, so it makes it harder for us to distinguish colors such as blue from black, or where an object ends and its background begins. So carpeting may be a hazard if it has different colors and dimensions to it. And the other thing is that needing more light to see well, and having that inability to sometimes adjust from glare. So those are common problems that occur just, as we age. And glasses or improved lighting, or just taking our time to do things sometimes can be beneficial in helping those. So what is a dilated eye exam? Basically what they do is you get drops put in your eye, it dilates the pupil, and the ophthalmologist is able to look at the back of the eye to see the retina and optic nerve, which is where a lot of these diseases will occur. It's recommended that everyone over the age of 50 should have a comprehensive dilated eye exam on an annual basis. And again, it can help detect age-related eye disease in its earlier stages when we have more of a chance to stop it. So some of the common eye diseases and conditions we're going to talk about: age-related macular degeneration, cataracts, diabetic eye disease, glaucoma, dry eyes, and low vision. These are some of the key eye-related diseases that will occur as we age. We're going to look at the symptomology and as well as who's at risk for them. So our first one we're going to talk about is age-related macular degeneration. Basically, it is damage to the eye's macula, which is the small sensitive area located in the center of the retina. The macula is needed for sharp central vision and for seeing objects clearly. There are two forms: dry age-related macular degeneration and wet age-related macular degeneration. In dry AMD, cells in the macula slowly break down and can cause blurry central vision. In wet AMD, abnormal blood vessels start to grow and leak, and this can lead to vision loss. So who's at risk for this? The greatest risk factor for this disease is age. Other factors that will contribute to it are smoking, family history, obesity, race. Caucasians are actually more likely to lose vision from AMD than any other race, but it can happen to all. And this next slide actually shows the vision change that occurs with macular degeneration. So you see the cute little boys very clearly on the left, and on the right, this is what a person with macular degeneration will experience. That central point has been lost. Some of the symptoms are no pain. They may have blurred vision, and then they have an early sign that's called drusen. And this can only be detected by the dilated eye exam. And drusen is yellow deposits under the retina. And if they notice any sudden changes in their central vision, you should encourage the older adult to seek an eye exam, because this may be a symptom that they have developed this. Some of the treatment options are, they have a study out that is showing that specific high-dose formulation of vitamins A, C, and E may be helpful with the addition of minerals zinc and copper. And then talking to the eye doctor about laser surgery, eye injections, or photodynamic therapy, which involves a special drug that's injected in your arm and attaches to new blood vessels in your eyes. And the drug is activated by a special light, and then it slows down vision loss by getting rid of the new blood vessels. So encouraging the older adult to seek health care when they experience that sudden loss would be paramount. Cataracts. A cataract is a clouding of the lens inside the eye. It cannot spread from one eye to the other. However, over time, the cataract may grow and cloud more of the lens, making it harder to see, and it can occur in one or both eyes. Those at risk, again, it's related to aging. Diabetics have a strong incidence of cataracts. Smoking and prolonged exposure to sunlight can also lead to a cataract formation. This is a slide that shows that normal vision, and then the same scene is viewed with a person with a cataract. So again, the clarity's not there. You have a little better vision than you did with the macular degeneration, but as the lens clouds, it can eventually lead to blindness and total clouding of that lens. Symptoms would be cloudy or blurred vision. Your colors may not appear as bright as they once did. Light from sun lamps or the from lamps or the sun may appear too bright. And at night, light from oncoming headlights causes more glare than usual. So that night blindness is actually enhanced in cataracts. Treatment options would be glasses, better lighting, and then they do have cataract surgery. And in fact, it is one of the most common surgeries performed in the United States. It involves removing the cloudy lens and replacing it with an artificial one. And there are some people with cataract surgery that may never need surgery, but many are able to postpone the surgery for years if they do develop the disease. So it is one that does have some treatment options. Diabetic eye disease. It's a group of eye problems associated with diabetes. Diabetic retinopathy is the leading cause of vision loss and blindness. It occurs when diabetes damages the tiny blood vessels inside the retina. A healthy retina is actually very necessary for good vision. So who is at higher risk? People, of course, with diabetes. The longer someone has diabetes, the more likely it is that he or she will get diabetic retinopathy. And a lot of that has to do with the changing of the lens from the influx of glucose going in and out of the cell. So here is actually normal vision. This is the same scene as viewed with a person with diabetic retinopathy. As you can see, there's pretty significant vision loss in an extensive case of that. So again, as with the other eye diseases, sometimes there are no early warning signs or symptoms, and early detection and timely treatment can reduce the risk of vision loss. So treatment options are laser treatment, surgeries. If the disease is detected early, timely treatment and appropriate follow-up care can reduce the vision loss or blindness by up to 90%. So it's really one of those that should be very much prudently watched with someone with diabetes. And in fact, most health care coverage will cover the dilated eye exam under health insurance as opposed to eye insurance because of this with the diabetic. Glaucoma. Glaucoma is a group of eye diseases that can damage the optic nerve in the eye. It can develop in one or both of the eyes. Primary open-angle glaucoma is the most common form. It's usually associated with elevated pressure in the eye, but the effect of the pressure can vary from person to person. It affects your peripheral or side vision, and if untreated, vision loss or blindness may occur. Primary open-angle glaucoma is the most common form. And those at risk are African Americans over the age of 40, everyone over the age of 60, especially Mexican Americans, and people with a family history of glaucoma. The vision seen on the left is, again, normal vision, and this is the same scene as viewed by the person with glaucoma. And as you can see, you kind of have this halo effect where they only see the central part and the peripheral vision has been changed a little bit there. So no early warning signs or symptoms. It's a painless disease, and there's a loss of your side or peripheral vision. And your treatment options are medications, usually eye drops. Laser or conventional surgery also may be beneficial in helping with that. If this disease is progressed, a person with glaucoma may notice that it's difficult to see objects to the side, while objects in the front may be still seen clearly. And left untreated, straight-ahead vision may decrease until no vision remains. The most common treatment options are medications, and it's very important to take the medications as directed. So basically what people can do for any of these eye diseases is comprehensive dilated eye exams every 1 to 2 years, or as instructed by your healthcare professional. And then the last one I'm going to talk about dry eye. And basically, dry eye is that the eye does not produce tears properly, or when the tears evaporate too quickly. If left untreated, it can cause pain, ulcers, or scars on the cornea, which is the clear dome-shaped outer surface that covers the eye in front of the iris, which is the colored part of our eye, and may cause some vision loss. It can make it more difficult to perform some activities, such as using a computer or reading for an extended period of time as you get eye fatigue. It can also decrease tolerance for dry environments, such as the air inside an airplane. It can be a temporary or a chronic condition. And those that are at higher risk are women. They experience dry eye more than men. And it can occur at any age, but may be more common with the use of certain medications that people will be placed on as they age. Some of the signs and symptoms would be stinging or burning of the eye, feeling as if you have sand or grit, episodes of excessive tearing following dry periods, a stringy discharge from the eye. You may have pain and redness of the eye, and then episodes of blurred vision. Heavy eyelids is another symptom. Decreased tearing or inability to shed tears when crying. People notice it when they're wearing contact lenses. The contact lenses become uncomfortable, and they actually have a decreased tolerance to any activity that requires prolonged visual attention based on that eye fatigue. Treatment options are using artificial tears, prescription eye drops, gels, inserts, and ointments, wearing glasses or sunglasses, and then getting punctal plugs. The eye care professional inserts little plugs in the drainage holes where tears drain from the eyes into the nose. But this is not a permanent treatment option. They can only do it on a temporary basis. And then the last one I'm going to talk about is low vision. Low vision is basically a visual impairment that is not corrected by standard eyeglasses, contact lenses, medication, or surgery. It interferes with our ability to perform everyday activities. Many of the conditions and eye diseases we talked about can lead to low vision, and even with regular glasses, contact lenses, medicines, people with low vision find everyday tasks difficult to do, such as reading the mail, shopping, cooking, watching TV, writing, or driving. So who's at risk? People who have eye disease, and some people actually who may develop vision loss after eye injuries or from birth defects. So our treatment options are vision rehab, and I believe Wayne, our last speaker, will be talking about that. And seeing a specialist in low vision, talking to your eye care professional about vision rehab, and using low vision devices, which could be a telescopic lens, handheld magnifier, or special software for your computer. So where can you go to get more information? The National Eye Institute through the NIH is a great resource, and in fact, on this next slide, we have the information about this PowerPoint and the toolkit that they have available. Thank you, and I will now pass it on to our next presenter.
Okay, thanks, Vicki. This is Sally Thorson. I'm an injury prevention coordinator with the Colorado Department of Public Health and Environment. And let me get this set up. I'm going to talk about that building block of building community-based fall prevention programs, vision exams, vision improvement, and the best practices regarding that. And I know we might have had some people join us after the first introduction, but we're going to have 3 speakers. There'll be 1 speaker after me, and then we'll open it up for questions. At any time you can type in your questions, and then we'll get to those at the end of the presentation. Okay. Let me get to my... Okay, we on this webinar series started out with an overview and then talking about the building blocks and education, exercise, medication review. This one is on the vision assessment, and then the next one will be on home safety, and then there'll be a putting it all together webinar. So we'll talk about vision as it relates to fall prevention. And I wanted to start out just with a story. A number of years ago, I heard a presentation by the head of the American Public Health Association, and she was talking about medical care costs. And her story was about getting new glasses and how she was hurrying to catch a plane, and she fell and injured herself. So she went on in the story about we've got to do something about keeping the cost of these medications down. She had health insurance and was able to pay for them. But I believe that her story also should have talked about preventing falls, and in this case it was related to vision. She got new glasses. Did she have an accurate correction? Was she given some tips or things that she could do to handle those glasses differently that might have prevented the fall? So vision is very much related to falls. And are we seeing people with vision problems? Well, yes. This is just one national survey where they asked people if you have trouble seeing even when you're wearing your glasses or contacts, and also included people who are blind, not able to see at all. And you can see it increases for both males and females as we age. So those over 75, at least 15% of the population would have some problems with vision, and that means anyone we have in our fall prevention programs, there are going to be people with vision problems. We've talked before about environmental factors for falls, and really when you look at all of these, they're all vision related. And so how we improve vision or help people deal with the vision they have, it helps reduce falls. For example, clutter, stair railings or grab bars in the bathroom, loose rugs. Those are all environmental hazards that we think of mostly as home safety, but they're certainly vision related. Pets, that's an interesting one. Pets are very beneficial to older adults, keep them active and engaged. Dealing with an animal, but they also, from age 65 and older, in the U.S. every year there are somewhere around 20,000 older adults that go to the treated in the emergency room for falls due to pets. The highest rates are people over age 65, and the highest fracture rate from these incidents are people over 75, and they can happen generally from falling or tripping over the pet. They might be pushed or pulled by a pet if they're walking a large dog, and then a lot of times it's people are just not sure what exactly happened involving the pet. More often with dogs than with cats. So we can talk to older adults about the benefits of pets, but also are there things that they can do to avoid problems with pets. For example, tripping over dog toys and dishes and things like that might be something that could definitely be looked at. And just dim lighting and floor surfaces that change in the home. And outdoors, of course, weather conditions. The picture down there is of yak tracks, which actually had a randomized control trial, and it reduced falls in the outdoor environment. So, you know, of course, perhaps more of a risk in places that are snow and ice for a number of months out of the year, but something like that that could be added to shoes when needed could definitely reduce falls. In uneven pavement and poor public health designs, public area designs. So that means for us to decrease older adult falls, we need to be sure that we're looking at solutions about making the environment friendly and walkable. Vicki talked about these, but the kinds of visual difficulties that may come from some of the eye diseases or from aging eyes, that visual acuity, which is of course what's normally tested in eye exams, but there's that, as Vicki talked about, contrast sensitivity, can you see details, edges or borders or contrast between light and dark, and depth perception. Some people have one eye that's not functioning and their depth perception's off, so stepping is going to be off. Just to reduce visual field from some of those eye diseases, impaired adaptation to the dark, so people turn on a light or go into a dark space and it may take a while to adjust. And the color perception, so particularly blue and green. So we can do a better job with our written materials, but also with our environment that older adults are in. And I just wanted to give some information about indoor and outdoor falls. The indoor falls are usually just slip, trips and stumbles. That's about 39% of the hospitalized falls. Falls on stairs, falls from furniture including beds, pets, as I talked a little bit about. And there, from hospital records, there's a large category of unknown causes of these indoor falls. So older adults may not realize it, or it may not be picked up in the chart, as healthcare providers are more keyed into helping that person than finding out what exactly happened. And then based on just one study that I read about, in Kaiser Permanente did a study over a number of years in Northern California with people who had indoor and outdoor falls to kind of characterize the outdoor falls. And these are for men 65 and older, or for older adults 65 and up. Men were more likely, about almost half the time, their falls were from in the garden, porch, or deck. Women, it was about 35% were on sidewalk, curbs, and street. And a lot of these were caused by uneven surfaces and tripping. Most of the time it was people just simply walking. Sometimes it was things like turning, reaching, being up on ladders, those kinds of things. So when we think about preventing falls, while the majority of the time of older adults is probably spent indoors, outdoor falls need to be addressed as well. And again, a lot of those solutions are getting involved in policy and issues about making the environment safer and more accessible. I wanted to talk a little bit about why vision is so important for balance and fall prevention. And I learned a lot of this from taking the N-Balance instructor class. When we balance, we really are relying on three systems. This is just for us to balance upright and be able to walk in a steady manner. Our visual system is the first, really the most important way that we generally learn to balance. The brain uses a target as your reference for balance. And the way you can tell that vision is really important is if in a safe environment you stand up and close your eyes. And after a few seconds, almost everybody will start to sway a little bit as their vision system is now not being used, and they rely on their other systems to provide their balance. The other systems are the vestibular, the inner ear system, and then the somatosensory system are receptors in your muscles, joints, and skin. So your feet on the ground, your rear end when it's sitting on a chair, your muscles and your joints all provide a balanced system. And so you can have deficits in one or more systems and work on compensating for those systems. So the brain will process all this information from the three systems and send signals to the muscles to initiate and correct balance. If you're starting to fall over, your brain alerts your body to that, and if you've learned the systems to correct your posture and balance, you may not actually fall. And you can improve those systems. Classes like N Balance have you practice on pads that will take away your somatosensory. You can practice by shutting your eyes in a safe environment, and those kinds of things can help you adjust, older adults adjust and adapt. So the high-risk groups are really, as Vicki talked about, the people who have the low vision from having actual conditions, or it can be just that aging process decreases our ability to see really clearly. And really everyone, even when we're younger than older adults, as we're moving about and get rushed and moving fast and our center of gravity is not set and we're doing complicated moves, we can all be at risk for having our vision impaired and increasing our falling. I know when I had my dilated eye exam a couple of weeks ago, I walked home because I couldn't see well enough to drive, but walking in the bright sunlight through the college campus environment with a lot of students, going from dark to light, really gave me the experience of what older adults may feel, and sometimes I just had to stop and wait until I could see a little better. So vision is really key for balance. Vision concerns also not only affects just our balance, but it affects behaviors. Like for me, if I didn't have the visual acuity so that I could knit, that would be something I would definitely have to adjust to. So low vision can cause people to change their social activities and their physical activities, whereas there are ways they could continue with those activities with some assistance. And lower vision people may be really afraid of taking exercise or any kinds of educational classes about fall prevention because they may not be able to follow the instructor well, and they may feel that they're just not safe in that kind of environment, not to mention transportation abilities in getting to a class. So we need to be thinking about people with lower vision. How can we assist them and make it easier for them to do the kinds of exercises that we know really work to prevent falls? And then home and outside hazards are things that can lead to people not being able to handle their own home environment, and what are the things that we can do to help them with that. So I looked at the literature on fall prevention and what were best practices, and I wanted to just go over those that help spark some ideas that we might have in what to present to older adults. Cataract surgery can prevent falls by increasing that visual acuity. And in particular, that first cataract surgery seems to be more key than the second one, probably just because they seem to operate on the worst eye first. And that actually somebody having cataract surgery may have a 35% decrease in falls. So we can do a lot of environmental changes and have them go to exercise classes, but cataract surgery is really key. There's also one study that looked at using single lens, not multifocal glasses, to prevent falls for older adults who are doing outdoor activities like gardening, walking the dog. So this would be instead of your bifocals or progressive lenses, if you're doing something where it's distance vision is the key thing, having single lens glasses for those older adults who are spending a lot of time outdoors can really be effective. However, for very frail older adults, there really doesn't seem to be much difference. So it's something to think about. It's difficult to change glasses, and remember to have 2 pairs of glasses with you, and as you're walking with a single lens, you may not be able to see details like signs that you need to read or that kind of thing. So there's advantages and disadvantages, but certainly helps with a lot of depth perception and seeing hazards. So those are 2 studies, and I looked at another study where they did a good study on a large number of people, over 600, who were older adults of 70 and older, and they got comprehensive eye exams, and if they needed new glasses, they got those. They were tested and managed for glaucoma, cataract surgery, and all of that. And the control group then of similar older adults didn't receive any of this special vision assessment and treatment, and it actually increased the number of falls in the group that received the assessments in vision. So my take on that is that simply improving vision is going to make people perhaps fall more as they get used to glasses and they haven't had other parts of their environment changed or improved. Then there are some home safety programs. The ones that seemed to be strongly effective were ones where they dealt with people with low vision. So people are visually impaired, and I really think about this as reaching fall prevention one subgroup at a time or one population at a time. So people with visual impairment, it's really key to do the home environment, and as well as adding exercise and other things. And also home safety programs, particularly visually impaired, seem to be more effective when given by an occupational therapist rather than just general home safety. My personal take on that is that occupational therapists don't just point out problems and ask people to take up rugs, but they deal with how can people navigate in their own environment. For example, this woman is out in an environment that's light and dark. She's got stairs. She's got a dog that she's dealing with. All of this puts her in a perfect position to have a fall. So an occupational therapist might walk through how can she get the paper in a safe environment. So we need to do more than just here's a checklist, do these things and you'll be fine. And then multifaceted programs that include exercise, home safety, and vision may be effective. There was one really good study that was able to give, some people got a vision assessment, some people got exercise, some people got home hazard assistance. And what they found is that of all of those, exercise made the biggest difference, but if they included exercise plus vision assessment and home hazard management, that was actually the absolute best of all of the interventions they tried. So we need to think about including all of those. And then just to also tell you something more about evidence-based programs, that exercise programs, and balance is one of those. They include vision improvement. During exercise classes, you might be moving your eyes, moving your head while seated, and also just walk and turn your head. So it gets people practicing movements that they might not be doing very much. Practice things in a safe environment with your eyes closed, and then walking with distractions. Have people walk in front of you and behind you to simulate being in a mall, and doing those in a safe, practiced environment can help older adults realize which systems they're using and how to improve them. And also I'm impressed with the part of the Stepping On class that includes a vision session. And here the session talks about more than just the standard educational things, but really helps people problem solve. Just things like, let's look how clean your glasses are. And I'm amazed sometimes at how I see so much better when I clean my glasses. Look steps ahead of you, so give people actual tips that they can use. 6 steps or a car length ahead when you're walking. Compact fluorescent bulbs give better light than the older light bulbs, and so that's something older adults can do or family members can do. Don't use walking areas for storage rather than just tell people to pick up clutter. Slow down, let your eyes adjust, and how to reduce glare. So the important point that Stepping On tries to make is get older adults to understand the link between vision and balance so that they're more motivated to make the changes. So these are the standard messages that CDC gives out about have your vision checked, and as Vicki pointed out, that is really key. Those medical guidelines say that some type of vision assessment is recommended at least every 2 years. That comprehensive dilated eye exam once every 2 years when you read some things, but every year when you read other materials, and that the message of early detection and treatment can make a difference in saving people's vision. There are some other additional messages that we can give older adults in any kind of setting about making sure your eyeglasses are updated, seek help with vision, ensure good lighting, and take exercise and other programs that are going to address vision deficits and help you cope. Some other kinds of messages about general messages to improve vision, that people realize it's going to help them be independent and help reduce their falls, are just taking care of their eyes, eating a healthy diet that may help them prevent some of the eye diseases. And also, I ran across this group, which others had not heard of, Eye Care America Foundation from the American Academy of Ophthalmologists. It's a public service program to provide eye care through volunteer ophthalmologists. They call them IMDs just because it's easier to remember. And these can be at no cost to people who qualify. Age 65 plus, have not seen an IMD in 3+ years, and then qualifications based on their income level. It's not designed to be something about providing glasses, but comprehensive medical eye exams with up to 1 year of care at no additional out-of-pocket expense, again based on the qualifications. And I did call this group, and they said they have some 80 IMDs available in Colorado. You can call this number or go online and fill out information about yourself or a client or family member and see where there might be a doctor available. So that's one option to help get these eye exams. Other community-based solutions, there's some limited screening that trained people can do just for visual acuity. The comprehensive vision exams, ophthalmologists in particular can do the dilated exams. And Medicare provides coverage for a dilated exam, so it can help people realize that they can have this covered. There are low vision programs, and then exercise and educational programs include help with vision. So our partners can be those ophthalmologists, optometrists, optician, the eyeglass people, primary care providers, Eye Care America that I talked about, Colorado Center for the Blind, and the evidence-based programs. So when you're thinking about who you need locally, how to find a champion in one or more of these groups. And that's my part of the program. Now I want to introduce Wayne Marshall. He works at the Colorado Center for the Blind as a case manager and counselor, as well as a technology and orientation mobility instructor with the Senior Services Program, and he's been doing that for the last 5 years. He teaches seniors how to safely travel within various environments, and often that's with the use of a cane, sometimes in conjunction with the use of a white support cane for stability and balance. So he's going to talk some about his experience in helping people adapt to low vision.
Good afternoon and welcome. Here at the Colorado Center for the Blind, we teach orientation and mobility to our seniors with the use of the white cane, and sometime with the use of a support cane. And in our first slide, you'd notice that our cane, the support cane, both canes are white as to indicate which is blindness, which is the national symbol for blindness and or low vision. We've been asked the question of how does one use both canes and why? Well, if one is blind or going blind, as many of our seniors are who have diabetes and macular degeneration, find that the long white cane is very useful, and we'll talk about in some of those ways of how useful it is and how it can be useful. But with the support cane, we know that diminished physical ability is one of the effects of aging, and so many of our seniors have fallen before and find that they are stability issues and need the support of a cane. Well, we use the white support cane because many of those seniors also have macular degeneration or diabetes as well, or some of the other eye diseases that are cause low vision or blindness. And so, you know, one could use either hand, cane in either hand, using the support cane for the side in which they need to use it most. And then one would, we teach our seniors how to use the cane in a manner which, when you step with your support, you then sweep with the long white cane as to clear your path. This allows the senior to safely have mobility in their area and maintain some independence while also maintaining the support necessary to move about. And our second slide will probably show myself out with a couple of our students. And one of the most important things, and I've heard mentioned by Vicki and both Sally as well, is surface recognition. In order to prevent falling from transition from one surface to another, it's important that they use the cane. That's one of our philosophies here, because it allows an individual to recognize the difference. If one is walking on concrete, you will be able to detect a line of transfer from that concrete surface to, say, grass or, say, asphalt. And many times on our travels, I'll have them identify that as to become conscious of it. Many of us travel, and we travel subconsciously, not being very aware of those, or we are able to detect them physically with our eyesight. However, when individuals are having diminished eyesight, it becomes very unreliable, and one becomes very fearful of traveling. So we work with our seniors in understanding different textual and surface changes. If an individual had a cane, you would recognize even the carpet, a rug, when it's raised or lifted, which would help prevent a fall. You recognize when you're going from carpet to tile, because the feedback and the information that you get from the cane is very important in that. Also, stairs. Stairs are very important, and as you lose in your sight, sometimes that blend, they'll blend together, and as well as the transition from day to night. Some of, as Sally mentioned, she got her pupils dilated. It was very hard for her to determine. It'd be difficult to determine, the depth, good depth perception or understanding when you're transitioning sidewalk to stairs. So you would notice the drop-off of the cane as it goes down, or as it dips, or as you descend. You'll start feeling that well before your foot encounters the stairs. So there's many reasons that we recommend our seniors use canes, and we're hoping that maybe you would do the same. I know that several of my seniors have found that even on ice, we have the winter coming up, and we know that even you can feel the concrete and you can feel the cane tip as it change. It'll slide or glide, or you'll feel it But even having that white support cane in the times of winter, it'd be very useful. Those canes have the rubber tip, although our long straight canes have a metal tip. And the purpose of that is for support cane, you lean on that for support, and so the rubber is to prevent it from sliding. Well, on the long straight cane, it's not for support. It's to detect and determine various surfaces, steps, drop-offs, and what have you. So, and that, we use a metal cane tip for that as to get great feedback and information of various textures. So I think that's pretty much it as far as how we work with our seniors with the cane. I would like to mention also that when one is adjusting to their environment, there's a lot of fear and anxiety and concern about falling, and also you know, being fearful of even going out to get their mail. But using the cane in your environment, which we work with a lot of seniors on, they become more confident and more independent. It helps them to maintain or to gain that confidence and independence in their mobility. And that's our goal, is to continue to have our seniors maintain their independence and their identity, and be able to move around safely in their environment.
Okay, thank you, Wayne. I'm giving Aaron's going to put up a slide about the next set of the next two webinars that we have in our schedule on home safety, and putting it all together, fall prevention in your community list where you can register for those. You have to register for each of these webinars individually, and there's the site where you can do that, and that's also where the seminars will be archived. And then Aaron can give us any questions that might have come up in the chat box.
So we did not have any questions come up in the chat box throughout the presentation. I have opened all the lines if anybody has any questions they would like to ask now. So if there are no questions, we can conclude the webinar. And I thank everyone for participating, and thank our panelists.
Sure, thank you.
Thank you.